So to keep this moving quickly, maybe I'll just say, Faye, you're on.
All right, thanks so much. Yeah, so I'm Faye Andrews. I'm a PhD candidate from Environmental and Occupational Health. This is my aim one in my dissertation, a prospective study of arsenic and manganese exposure, maternal blood pressure during gestation. So a few studies review environmental stressors on maternal cardiovascular health. So we looked at a birth cohort in Bangladesh to test the hypothesis that women with higher arsenic and manganese exposures are associated with increases in blood pressure levels over pregnancy after adjusting for confounders. We used repeated measures of monthly diastolic and systolic blood pressure, and we reviewed the exposure assessment of arsenic and manganese by first drinking water at enrollment, as well as toenails sampled at 1 month postpartum. And that toenails are a great way to look at metabolized arsenic and manganese exposures for women over pregnancy. We use covariates of age, education, monthly income, BMI, cook fuel type, and clinic location. And for the statistical analyses, I use linear mixed models so that I could account for the inter and between women changes in blood pressure over time, as well as looking at effect modification of BMI, because BMI typically higher BMI increases blood pressure at baseline. So the next slide will be my results. And we used linear mixed models to predict exposure response relationships between specific drinking water arsenic levels and change in blood pressure over gestation. So I have two graphs here of systolic and diastolic blood pressure, where those levels are on the y-axis, and then on the x-axis I have gestational age in months on the x-axis. So we use these predicted levels of arsenic, and at 10 micrograms per liter, which is the green line at the bottom, is the US EPA and the World Health Organization regulation level for arsenic in drinking water. And so over time of gestation, we see the typical increase in blood pressure in women over gestation, but we see a 3 to 5 increase in millimeter mercury of blood pressure, followed by the arsenic at 50 micrograms per liter with the blue line across the graphs. We see this increased slope. So this is what we're trying to find with these linear mixed models, is this increased slope over time of increased blood pressure and the changes by these levels of arsenic. We moved to 250 and 500 microliters, where we're pushing women into elevated blood pressure levels over 120 and 80 microliters.
30 seconds left.
All right, and so some of the takeaways from this, manganese actually has a nonlinear effect, so I need a ton more slides to describe that effect. But overall, these are preventable exposures for women over gestation, and more research needs to be found out about what these effects can implicate.
Perfect timing. Next slide. There it is.
We'll hold questions till the end. Whoa, I think we need to go back. Okay, the next presenter is Chandra Char, and take it away, Chandra.
Good morning. My name is Chandra Char. I am a PhD candidate in health promotion, health behavior, and this is my project examining anticipated healthcare stigma among adults with rare diseases. So there are more than 7,000 different rare diseases, and people with rare diseases who experience anticipated healthcare stigma from healthcare providers are less likely to access healthcare. So although rare diseases may vary in etiology, symptoms, and severity, many rare diseases are chronic, and the struggle often comes from trying to find a diagnosis. So due to the uniqueness of rare diseases, many healthcare providers may not be knowledgeable about treatment options or be in a position to educate patients about their condition. And so this can impact patients' trust in their provider as a source of information. So the purpose of the study is to determine the relationship between number of rare diseases and anticipated healthcare stigma for adults in the US with rare diseases. And I'm looking at turn to physician for information, satisfied with physician as a source of information, and trust physician as a source of information as moderators. Next slide, please. So this project analyzed, was a secondary analysis utilizing the Adults with Rare Disorders Support Study. In the study, we had 1,218 US adults who were diagnosed with one or more rare disease. And anticipated healthcare stigma was measured through the chronic illness anticipated stigma scale. The data was originally collected in 2017. So here we have some preliminary results. So bivariate analysis was used for my preliminary analysis of the relationship between number of rare diseases and anticipated healthcare stigma, and the moderators and anticipated healthcare stigma. So results suggested that individuals with more than one rare disease experience more anticipated healthcare stigma. Anticipated healthcare stigma was low for individuals that reported high satisfaction with information from a provider, and anticipated healthcare stigma was high for individuals who do not use a provider for information. And anticipated stigma was high for individuals with low trust in their physician. So what is the point of all of this? Well, the results of the study help inform us of information-seeking behaviors of individuals with rare diseases. And the study also informs us of the role of trusting a physician and the role that it plays in anticipated healthcare stigma and healthcare experiences, of patients with rare diseases. Thank you so much for your time.
Thank you, Chandra. Okay, let's go. We're on to Kendra Sims.
All right, I'll be giving a big picture motivation, kind of a big picture scope of my dissertation, which was motivated by key gaps in the biomedical understanding of how experiences of discrimination might impair the control of high blood pressure among a diverse sample of middle-aged to older adults. The motivation was that by focusing solely on established behaviors and patient characteristics and considering inequity as a fundamental stressor, health professionals will largely fail to meaningfully intervene on the excess disablement and mortality among marginalized groups, such as people of color and those of low socioeconomic status. We sampled from over 14,000 participants from the health and retirement study. We used logistic mixed regression models for the first aim, where we observed that reported an equal treatment over the lifetime, as well as in everyday life, due to at least two reasons, meant that participants were more likely to develop or less likely to recover from hypertension over 4 years. There were not significant differences by race or ethnicity. Instead, it appears that these associations were primarily driven by the men who seem to be experiencing impaired blood pressure control due to intersectional discrimination. For my second aim, I used four-way decomposition mediation analyses that have been advanced by Tyler Vanderweel. And it showed that there was a modest mediating effect of depression symptoms on the use of antihypertensive medication. And for the third aim, factors such as 1 minute. Yes, I was like, I didn't think I had 30 seconds. That at the census tract, county and state, to look at hypertension as like structural ways that inequality might affect hypertension. And it seems that states at the state level, areas where there were more female-headed households and more older adult men living alone were among the factors that were associated with hypertension prevalence among a sample that may be marginalized in unique ways. We can advance.
So you only do have, you have 15 seconds now.
All right, so that's why research comes first and introduction comes last. I am Kendra Sims, and a doctoral candidate at the Department of Epidemiology, and thank you so much.
Thanks.
Yeah.
Thank you, Kendra. Next up is Brooke Reeves. Is Brooke on?
I'm sorry, I was muted.
Okay.
Hi, everyone. My name is Brooke Reeves, and I'm in the Master's of Science in Nutrition and Professional Dietetics program. The PI on my project is Dr. Jenny Jackson. My capstone project is a part of a multi-state study, including Brigham Young University and the University of Hawaii. The overarching goal of the multi-state project is to explore and more deeply understand food insecurity in the college student population, and then to be able to identify nutrition intervention strategies to address underlying factors of food insecurity. The specific aim for my capstone project was to adapt the USDA FSSM for the college student population to more accurately measure the prevalence of food insecurity. The USDA FSSM is the United States Department of Agriculture Food Security Survey module. This survey tool is used to measure food insecurity among US households. However, it was never validated to be used in the college student population. So this has raised concern that the estimates of food insecurity in this population may be inaccurate. When I say food insecurity is defined as the lack of consistent access to enough food for every person in a household to live an active and healthy life. And I'm going to paste a link to the survey tool to the USDA FSSM in the chat box in case anyone is interested in seeing it. And we can move to the next slide, please. So participants were recruited through the Student Experience Center and the Human Services Resource Center here at OSU. A recruitment email with a link to a screening survey was sent to approximately 375 students. We had 14 students respond to the survey, and then 8 were selected to be interviewed. I aim to have a diverse sample of students due to the small sample size, and you can see the demographics of the participants we interviewed in the bottom left box on this slide. The 8 interviews were conducted over Zoom, and they were audio recorded and transcribed through Zoom. For the interviews, participants were asked to discuss each item of the USDA FSSM in addition to questions relating to their household and income. To analyze the interviews, 2 researchers individually reviewed each response to each item of each interview and made summary notes. Next, we compiled notes from each interview and compared results across all 8 interviews. Lastly, based on all of the participant feedback, we made suggestions on how we would adapt each item of the survey tool to be better understood for other college students.
30 seconds left.
We found most questions on the USDA FSSM to be confusing for college students to answer. So this study supported the concern that this survey tool may be inaccurately measuring food insecurity in this population. These same methods have been used at the other participating universities, and the next steps are to compare our adaptations, suggestions, and combine them to create a new survey tool. And after that, the team plans to conduct focus groups and a pilot study to validate the new survey tool to accurately measure food insecurity in this population. Thank you.
Thank you, Brooke. Next up is Abby Mulcahy.
Hi, good morning. My name is Abby Mulcahy, and I'm a PhD candidate in public health policy. I'm presenting my dissertation titled Transgender Adults Living with Disabilities, Factors Associated with Healthcare Utilization. Both transgender adults and adults living with disabilities are underserved and understudied and struggle to access healthcare. Existing research either examines transgender adults and adults with disabilities as separate groups or frames disability as a health outcome a transgender person may experience. Studies focused on transgender adults living with disabilities are limited. In this study, we investigated the relationship between disability status and healthcare utilization among a sample of transgender adults. We addressed the following specific aims. 1, compare healthcare utilization by transgender adults living with and without disabilities. 2, examine what predisposing and enabling factors are associated with healthcare utilization for transgender adults living with disabilities only. And 3, compare factors associated with healthcare utilization for transgender adults living with and without disabilities. Next slide, please. We use data from the 2015 United States Transgender Survey and guided by the Gelberg-Anderson behavioral model of health services use for vulnerable populations, and using logistic regression models, we compared healthcare utilization for transgender adults living with disabilities to those living without disabilities. We also examined the association of age, race, visual conformity, victimization, psychiatric distress, location of residence, level of education, and health insurance status with healthcare utilization among transgender adults living with disabilities. Using an effect measure modification analysis, we examined whether disability status modifies the relationship between covariates and healthcare utilization. Transgender adults living with disability compared to those without were significantly more likely to utilize healthcare. Among transgender adults living with disabilities, older age, higher educational attainment, victimization, and having health insurance were positively associated with increased odds of healthcare utilization. Psychiatric distress was negatively associated with healthcare utilization. Comparing factors associated with healthcare use for transgender adults living with and without disabilities, the magnitude of effect differed for psychiatric distress, educational attainment, and health insurance status, and was greater for transgender adults living with disabilities. These variables are marked with an asterisk in the table. Finding from this study will inform policies and practices to increase access to and utilization of healthcare for transgender adults living with disabilities and other multiply marginalized groups. For example, since transgender adults living with disabilities who experience psychiatric distress were less likely to have utilized healthcare, we recommend training healthcare providers and administrative staff to minimize bias and discrimination in healthcare settings. Thank you.
Thank you very much, Abby. And the last presenter for this first session is Heesu Lee.
Hello, this is Heesu, a doctoral student in the HDFS program. And today I will talk about how we can help close the digital divide for older Koreans. Now, a lot of older Koreans can access the internet, but that does not mean they utilize it as much as younger adults. If we quantify average Korean's ability to use the internet as 100, older adults' ability is about 60s. So I wanted to know if informational support helped them use the internet better, and if so, if the sources mattered. In this study, I looked at the sources of support as well as relevant skills and attitude and their impact on internet use. I used a secondary data set from Korea. The sample characteristics are in the slide. And I examined the impact of support separated by men and women, and if it was mediated by skills and attitude. Personal support source means someone the participant personally knew, and professional source is professional services such as customer centers. Internet skills indicate the ability to use mobile devices such as smartphones or tablets, technology attitude, how confident they feel toward using new technologies. Internet utilization means the use of various content and tools in internet, such as SNS, searching for or sharing information, online banking, and such. These are the analysis. The rest two are in the next slide. As you can see, the structures are different here. Oh, the previous one, please, not yet. For men, personal support impacted internet use only through attitude. There was no direct effect of support on internet use either. However, for women, there was direct effect of support, and it was mediated by both skills and attitude. Next slide, please. Now, these two structures are similar. Professional support for men and women are mediated by both skills and attitude. However, for men, and again, there is no direct effect of support on internet use. This particular analysis was performed because I assumed that information support would strengthen one's skills, which would then impact attitudes and then one's internet use. This was true for men with professional support and women with personal support. However, for women with professional support, this was not true. This study showed that information support can help older Koreans utilize internet regardless of the source and for two genders. However, personal support may be especially important for women in that it has direct effect and had 3 indirect pathways that impacted internet use. Accordingly, personal support for women and professional support for men may be most beneficial in helping them utilize internet more, and we should make efforts to strengthen those support sources. Thank you.
Thank you. Thank you very much, Heesu. Okay, now we have a few minutes for Q&A, and I have to start by saying I'm very impressed by all of these and also by how quickly you all can speak. Yeah. You really took advantage of those 3 minutes. That's great. So let's open it up for some questions for the first 6 presenters. If you want to, you can either just unmute yourself and go ahead and ask.
Can I ask a question?
Yes, please.
Okay, I have a question for Faye. I wanted to ask, I'll just ask all the questions at the same time. So you in your covariates, I did not see parity was controlled for. Neither were any comorbidities, like you mentioned BMI, but besides BMI, people can be hypertensive. So that was not included. I didn't see that. And the graph which you showed, none of the values of the blood pressure readings seemed high, whether it was systolic or diastolic. So Did you all get more or like higher readings, or this was all that you all got?
Yeah, thanks so much. I think what will cover a lot of your questions is that we had an extremely healthy cohort. We actually didn't have a lot of comorbidities of preeclampsia, gestational hypertension, or hypertension before women went in. Parity is something that I need to work into that you mentioned, but typically wasn't as much of a, the literature didn't point to it, but it's something that I can definitely add into it. As well as for the levels, those were predicted levels based on the exposures that I put into the model. There were definitely very high levels, but we had a wonderful, all the women were actually at baseline where it had the normal levels of blood pressure, and very few were pushed into elevated levels. We actually don't have the birth blood pressure level, which is a limitation, but what we're seeing is that even all these healthy women, they can potentially be pushed into it later in gestation. And if they, future research is if women have predisposing, chronic conditions, that they might actually be really be in danger later in health, later in gestation because of that. So.
Thank you.
Some more questions? I'm not seeing any, so I'm going to ask one question. Kendra.
Yes.
Very interesting study using the HRS. And I know the HRS, there's those questions about discrimination, and there's lots of different types of discrimination.
Yes.
Did you just form a variable summing all of the different types of discrimination?
In the first chapter, I assessed it continuously. So it was looking at the frequency of everyday discrimination within the past 12 months. So that was from never to almost every day. There weren't really significant differences.
Oh, I'm sorry, I'm not.
Reasons people.
It might be on my end, I don't know, but you froze for me.
Did you catch any of it? I don't want to.
I think you said there was a continuous variable, and it was a question about everyday.
Right.
Everyday
yes.
discrimination.
Yes.
So
yes.
the person,
yes.
him or herself, just kind of talked about it all, because I know there's specific questions about what type of discrimination. Yeah.
Yes, because there's also the lifetime, which I evaluated separately. So that seemed to be where significant effects were seen among the men. And then you can report, And
I was surprised that it was, primarily driven by the men. I was actually very surprised by that finding. So interesting.
I mean, between 2008 and 2010, I think we frankly need to think that maybe white lower class men who are older adults were discriminated against. So we have to, our work should build compassion.
Okay, lots of nuances in there. Thank you.
Yep.
Yeah, we might have time for another question or two. Do we, Marie?
Excuse me. Yes, we do. We have 4 seconds. 4 minutes. So please ask questions, people. I'll check to see if anybody's got a hand raised here.
Okay. And please feel free to just unmute yourself and jump in with a question.
So Karen, I often say if there isn't another question looming and we have just a little bit of time, do any of the speakers have something else they'd like to add that they had wanted to say in their presentation but didn't have time?
Or I might want to ask a question to all of the presenters. What was the most difficult part of doing your research?
Good question.
I have an easy answer to that. Finding a data set was really hard. We don't collect a lot of, we as like a country don't collect a lot of transgender data. So finding a data set that I could ask questions about that also included disability was the hardest part of getting started.
I was fighting a lot of scope creep because I think like a lot of us, we want to like solve a lot of big problems, but we also want to do it in a finite amount of time. So can't do everything at once.
Very common problem.
This is Chandra. Yeah, I think the hardest part for me was balancing this project in addition to my dissertation. Time is always thy enemy as a doctoral student.
I would say actually believing my results were what they were, and I was trying to pick them apart. And I didn't believe that what I found was I did it right, or I need a lot of iterations to figure it out, a lot of other things. So I think that was one of the hardest parts to put it all together, and then actually apply it to clinical settings and what the results really mean.
If I may add, the consistent insecurity, asking myself, am I doing this right? Am I doing this right? And I don't have the answer yet.
I'd say for me, definitely COVID threw a wrench in our plans a couple times. And then also balancing, I was doing my dietetic internship while doing my research. So it's been a busy year.
Well, thank you all for being willing to share not only your research, but also your perceptions of what might have been the most difficult part of doing this project. And thank you, Ellen, for that interesting question. I think it might be time to move on.
Yes,
Yeah,
Karen,
great.
you can move on.
Molly is saying in the chat, it was great to hear all about your work. Okay. Moving on to session number 2, we're going to kick it off with Mandana. I hope I'm pronouncing your name right. Go ahead.
Hello, everyone. I'm Mandana Matsuura, and I'm first-year PhD student in health policy. My research is about the effect of the ACA Medicaid expansion on disparities in the use of sexual and reproductive health services for women of reproductive age living in Oregon rural and urban areas. One of the public health priorities in the United States is ensuring that women of reproductive age have access to sexual and reproductive health services. In comparison to those in urban areas, adults living in rural areas experience different sexual and reproductive health outcomes due to differences in their health behaviors, and they also face challenges such as shortage of providers to accessing sexual and reproductive health services. Under the Affordable Care Act, states have the option to expand their Medicaid coverage to non-elderly adults with income below 138% of the federal poverty level. Oregon expanded its Medicaid program in 2014, and this expansion could lead to increase in coverage in the rural areas. But there is lack of evidence on the impacts of the ACA Medicaid expansion on rural and urban disparities in the use of sexual and reproductive health services. To fill the gap in the literature, our study has 2 specific aims. First, the use of sexual and reproductive health services for Medicaid enrolled women of reproductive age living in rural and urban areas of Oregon. Second, assessing the effect of the ACA Medicaid expansion on disparities in the use of Medicaid finance sexual and reproductive health services for women of reproductive age living in rural and urban areas of Oregon. Next slide, please. Thank you. We will use Oregon Medicaid claims and enrollment data from 2008 to 2016. We will divide our study population into 3 exposure groups: pre-ACA, post-ACA non-expansion, and post-ACA expansion groups. We will use logistic regressions and linear regressions to achieve our 2 specific goals, and models will control for demographic characteristics and trends. We hope that the result of our study will advance knowledge of the impact of the ACA Medicaid expansion on rural and urban disparities in sexual and reproductive health service use, and will provide valuable information to states who have not yet expanded Medicaid coverage to low-income women. Thanks for your time.
Thank you. Dimitris is presenting next.
Hi everyone, my name is Dimitris Athanasiadis. I'm coming from Greece. I'm on the biophysical concentration in kinesiology, working on the neurobiomechanics lab. The slides that I'm going to present to you is about my meta-analysis that we are conducting as of right now. And the title is food posture associated with musculoskeletal injury related biomechanics during dynamic landing activities. Next slide, please. So what's our systematic review so important? There's a big gap in the literature, and one of them is how do we classify the food? What are some cutoff values in order to say if you're a flat foot or if you have a high arch feet? And therefore this leads to a confusion on how do we interpret the results that we get from there. There have been some studies that have been conducted during standing, walking, or running activities, but nothing closer to sport activities like cutting drills or pivoting maneuvers, where they have this kind of dynamic landing where your foot pretty much hits on the ground very hard. And we see a lot of, as we call them, non-contact injuries. So this is what we're going to try to find right now in our systematic review. We are still on the data collection process, so I hope I will find some nice and fill up the gaps in the literature. Thank you.
Thank you very much. Hannah.
Good morning, everyone. I'm Hannah, and I'm a student in the Master's of Science in Nutrition Professional Dietetics program, otherwise known as the MSNPD here at OSU. And today I'll be talking briefly about my capstone project that I've been working on that aims to better understand the impact of malnutrition intervention in cirrhotic liver disease patients through a study of screening tool performance and patient care outcomes. So identifying protein calorie malnutrition in cirrhotic liver disease patients is crucial. And this is because 90% of those malnutrition affects up to 90% of those with symptomatic complications in this population. So the aim of my project has been to investigate how well the generally validated malnutrition screening tool captures protein calorie malnutrition in cirrhotic patients compared to an assessment, a full nutrition assessment performed by a registered dietitian. And I'm also aiming to evaluate whether there is an association between nutrition intervention by way of a simple evening snack and hospital length of stay, 30-day readmission, and 30-day mortality. And this is based on data that was gathered at Good Samaritan Regional Medical Center in Corvallis, Oregon, back in 2018, which suggested that something as simple as just a bedtime snack could actually improve patient outcomes by reducing time between feedings. Next slide, please. So the etiology of malnutrition in cirrhotic patients is multifactorial. This patient population may have decreased oral intake resulting from things like gastrointestinal distress, ascites, fatigue, nausea. They may also experience decreased utilization of nutrients, possibly due to bile acid deficiency and fat malabsorption. And the big one is altered macronutrient metabolism. So these patients may experience abnormal carbohydrate metabolism, increased gluconeogenesis, where their glycemic homeostasis is lost and their glycogen stores become depleted, and protein catabolism also increases. So the takeaway here is that it's estimated that the observed catabolic state of a cirrhotic patient after fasting for just one night, after dinner to breakfast the next morning, is similar to 2 to 3 days of starvation in healthy individuals. So this is why reducing time between feedings via a simple evening snack may make a relevant difference in this population. So I'm still working through the data analysis for this project, and I'm currently investigating the difference between malnutrition diagnosis and malnutrition screening tool score through construction of a contingency table to estimate the specificity, sensitivity, negative predictive values, and positive predictor values. And I suspect that the simple 2-question malnutrition screening tool, which is otherwise appropriate for a general hospitalized population, is not appropriate on its own in cirrhotic patients specifically. So I suspect that there will also be a difference in length of stay, which could also translate or would translate to differences in cost of care between those who received a bedtime snack and those who did not. So once this project is completed, my hope is that it may help to lay some groundwork that contributes to improved care and quality of life in cirrhotic patients. Thank you.
Thank you very much. Primika.
Yeah, hello. My name is Primika. I'm a second year MPH student in environmental and occupational health. So today I will talk about my internship. I was interning with OSU Environmental Health and Safety, or EHS. So my project was about OSU injury data analysis from 2015 to 2019. So next, please. And for the aims of this project is were to analyze the injury data from 2015 to 2019. And this project can add more and analyze the injury data from 2020 and so on. And this project can see the trend of injuries at OSU and to prevent and control injuries. And for the methods to find the OSU incidence rate, I estimated by using the injury status or insurance claims from the OSU employees. And there are three categories, including first aid or near miss, medical attention, and harm loss. But I use only medical attention and harm loss to parallel with BLS incidence rate calculation as formula shown below. And next, please. Next slide, please.
So I think you had 2 slides.
Oh, really? I have another one.
I'm sorry, I only saw 2, and that was what I was expecting as well.
Okay.
Can you present without your slide?
Yeah, sure. So for the significance finding, so I in 2015, the incident rate was lower than other years because maybe employees reported injuries less than other years. And in 2019, the incidence rate was higher than other years because it might be due to the OSU employees reported more injuries or incidents in OSU had increased as a whole in 2019. And for the for the implications, so to decrease or reduce the incidence rate or number of injuries, so we can reduce the injuries in non-labs and food service that has most injury occurred than other sectors like Spain, stain, and burns. Yeah, that's all. Thank you.
Thank you so much, Primika. Interesting, and sorry you had to just sort of.
Sorry for my side.
That's fine. Thank you so much. And the next presenter is Jacky.
Hi, everybody. My name is Jacky Leung. I'm a PhD student in global health. The topic of my presentation is impact of COVID-19 on Micronesian families, access to education and health services. So some background information is for the past 2 years, my nonprofit has worked along with an academic partner at Washington State University to engage in leadership training for Micronesian Islander parent leaders who are parent and caregivers of children from anywhere from prenatal to age 8. Prior to COVID-19, the core group of participants and academic research team met on a monthly basis, receiving training on public engagement, leadership, and other topics. But since COVID, our team has switched to 100% virtual format. Other than not meeting in person, providing on-site childcare, we still work on ensuring that the community needs are met through delivery of food. We also have provided small gift cards for their participation. After the pandemic was underway, we ended up canceling 3 in-person sessions, but by May of last year, we switched to a virtual format utilizing Zoom. We had a total of 7 participants, and we continued to meet on a monthly basis, focusing on how the pandemic has affected them personally. So some of the information that we've collected so far, health education wise, is that the Micronesian Islander parent leaders have shared their frustration with the experience with education. The reaction to virtual learning has been mixed at best. Most parents preferred in-person instruction because it was easier to speak with teachers. At least one parent leader described their child, who was a straight A student in person, who now receives C's and D's. It is next to impossible for that parent to contact the teachers to schedule appointments to find out what's happening. Since then, since earlier this year, or around last month, the last 2 months, school for the age groups now has either become comprehensive distance learning hybrid, where they meet in person for a limited amount of time, or virtual. Most parents have now resumed the hybrid version, except for 2 who'd elected to remain virtual. One other important thing to note is that one parent who had a child in high school and one in middle school, one who did well in person, didn't do well virtually, but then the other one who wasn't doing well in person thrived in the virtual setting. So it was very interesting for that parent to share that perspective. For health-wise, the parent leaders postponed care, partially due to appointment unavailability and fears of going out and being exposed and getting sick, and or their children getting sick. So now the parent leaders are starting to return to appointments, but at the same time, they're still continuing to follow best practices, including wearing masks and washing hands as much as possible. So the next step, there's 2 more workshops for the leadership program. We're also going to be doing a virtual graduation and starting a new grant opportunity focused more on education access, specifically for families with children who are trying to get into early childhood education. Next slide. So this slide I wanted to show you, this is when we were still in person. This is pre-COVID, but this is during the first year of the program and some of the graduates from that program from the first year. Thank you.
Wow. Thank you so much, Jackie. And our last presenter in session 2 will be Julia.
Hello, my name is Julia. I am a PhD candidate in health promotion, health behavior. We're going to be talking about part of my dissertation today. So adolescent and young adult, or AYA, cancer survivors are anyone diagnosed with cancer between the ages of 15 and 39 years old. And a cancer diagnosis and treatment at this age can severely negatively impact sexual health in a number of different ways. But despite this, there's a big gap in patient-provider communication around sexual health in AYA cancer care. So overall, my dissertation is looking at whether social media, and specifically Twitter, may be able to bridge this gap in communication. And part of this is determining whether and how sexual health is currently being talked about in the AYA Cancer social network on Twitter. So to answer this question, I used R-Tweet, which is a package in R, to collect tweets containing keywords that were related to AYA cancer. And then I extracted tweets that from this network that were related to sexual health specifically. So tweets that were related to sexual function, body image, dating, relationships, etc. And I examined the self-provided profile information of each tweet's author to determine what type of stakeholder role they had. So whether they were a survivor, a healthcare provider, researcher, etc. And then I conducted an inductive content analysis of the sexual health related tweets. If you go to the next slide. So these are some preliminary results. So these tweets were collected between April 5th and May 3rd of this year. They were all from the AYA Cancer Network on Twitter. So 72 Twitter users authored 97 tweets about sexual health. Twitter users included health-related organizations, cancer survivors, researchers, healthcare providers, hospitals and clinics, and others, things like media websites, friends, partners, patient advocates. Then tweets were coded based on their purpose and their content. So in terms of purpose, most tweets were sharing personal experiences or resources. Many of the tweets aimed to spread sort of general awareness of sexual health as a common issue for AYA cancer survivors. And some tweets discussed different aspects of research on this topic. And then some described some unmet needs related to sexual health in AYA cancer care. The topics of the tweets were primarily about general sexual health and function, body image, and dating as an AYA cancer survivor. Some tweets were about cancer's impact on romantic relationships and then sexual health communication, both with providers and with partners. And so although these results are really preliminary at this point, they do suggest that AYA cancer survivors are using Twitter to share their experiences related to sexual health. And it also tells us that resources to address sexual health issues are being shared in this network, mostly by organizations that serve cancer survivors. So healthcare providers and other stakeholders can use the AYA Cancer Network on Twitter to gain a better understanding of survivors' sexual health related experiences and needs. They can keep up to date on relevant research, and they can also become familiar with sexual health resources that are available for AYA survivors. Thank you.
Thank you very much. And again, we can unmute and clap maybe, or put the little symbol up. Great presentations, all of you. Fascinating interdisciplinary topics here. Yay. And let's open it up for questions. I know there has to be lots.
I have a question for Julia. I was wondering how you chose the questions or phrases, I mean the words or phrases that you decided to filter through all the tweets.
Yeah, so there were sort of two steps to that. There was collecting tweets that were related to AYA cancer, and I used, I started with a couple of sort of general terms like hashtag AYA cancer, hashtag AYA CSM, which is AYA Cancer Societal Movement. And then from there, I kind of looked through what came up from those tweets and found more keywords. And then once I got those tweets, I sort of did a similar process with sexual health. So I started with words, general words like sex, body image, libido, things like that. And then as I filtered through those tweets, I found more keywords in those tweets to search through the rest of it. I don't know if that made sense.
Yeah, totally. That seems like an extensive process. Thank you for sharing.
Yeah.
Looks like Nancy maybe has a question.
Hi, I have a question for Julia. Did you encounter any tweets that were like pushback from people that were not part of the AYA community?
Yes, I did. Some of the keywords that I used were like cancer and infertility, because that's a specific issue for AYA cancer survivors. And unfortunately, there is a lot of tweets about like the COVID vaccine causing both cancer and infertility, or a lot of negative tweets about the recent bans around trans healthcare, like hormones causing both cancer and infertility. Just a lot of general misinformation.
So I have a question, Karen, if that's okay.
Absolutely.
So it's for Jacky. So Jacky, you mentioned that you had just received funding for a new program. Could you tell us more about that? That's exciting.
Yes, so we received some funding to actually develop, make a program that was already made for the Latinx Spanish-speaking community to make it more culturally relevant now for the Micronesian Pacific Islander communities. So for the next year, we're going to be modifying that curriculum to be more culturally specific and transcultural for our community, and be able to pilot test it in the upcoming year. Our goal is to get at least 45 parent leaders to be trained on this curriculum so that they could then possibly implement it at home, and then follow up with them and see how they enjoyed the program.
Thank you. Thank you.
Quick question for Dimitris. I think it's interesting to look at dynamic landing activities. And I'm wondering how you standardize, or do they standardize in these types of studies, the types of shoes, running shoes people are wearing?
Yeah, that's a very nice question. Thank you for asking. They don't actually, some of them, they are getting fundings and they basically receive a large batch of shoes from a sponsor. Most of them, they are saying that they have similar characteristics, which is very vague. Some others leave it more open and they say, we want this variability because it's gonna go closer to the real life situation. But on the same time, we know that we as researchers causes us a lot of trouble on interpreting the results. So the majority of the studies that we have seen so far, it's been unsought conditions, so without shoes, but there are some others with shoes, and we try to separate them a little bit into clusters. Again, it's a big process, and we're trying to navigate through all of these inconsistencies.
Thank you.
I have a general question for anyone who is planning or did use primary data collection. How do you expect your assorted findings or even your hypothesis to maybe change based on, you know, the nice natural experiment we're all living in?
Well, I could kind of answer so far what we've been doing. So in the past year, with taking consideration, we went from in-person to 100% virtual. We've actually been able to get some articles published. We had 3 published last year, specifically centered on the curriculum development, how we had to adjust to those changes. And with some of the information I just shared in today, we're working on another article that talks about how COVID has now impacted the community and how they've had to adjust to the virtual world themselves.
Great answer.
Good question. Anybody else who collected primary data?
Yeah, I can add, my data is collected through Twitter, so it didn't really affect like the in-person, you know, I didn't have to do anything in person, but definitely added a lot more tweets that were irrelevant to my research question, but lead to a lot of other research questions. So yeah, if anybody's interested in looking at public opinion on any, you know, COVID vaccines or anything health related, Twitter is a very interesting place.
Oh,
I
lots of different opinions.
for using that. I think that's really innovative, and so I'm pleased to learn about this R tweet data.
I'm installing R tweet. This is amazing.
So Karen, we still do have a little more time for questions. So I'm putting that out to everybody. Ellen, do you want to ask your question of this group?
Yeah, should I repeat it? What was the most difficult part about doing your research project?
Feel free to unmute and just go ahead and answer Ellen's question.
Oh, go ahead. I was just going to say, I mean, as someone previously mentioned, COVID really made things difficult kind of with delays and data collection and also communication, just having to do everything remotely, making sure that, you know, I was on the same page as my site supervisor and my PI. There was just some a steep learning curve there, but we're getting through.
Good.
I have to echo Hannah for the most part in terms of, you know, the fears and concerns of working within our community. And when COVID first started, the Micronesian community was hit the hardest, and to make sure. And so we went from focusing on, you know, these important topics to talk about, like, what are your needs? What are things that we could help you with? Like, is there any kind of support mechanisms? So we went into emergency preparedness, trying to help them with any kind of services, making sure that they knew the information and resources were out there that they would be eligible for. Taking consideration some of their citizenship statuses is very different, and it makes it impossible for them to be eligible for some programs that other folks would be eligible for.
I believe that one of the steps that is kind of hard is the first step, when we should find a topic that is important, that it's interesting, and find the gaps in the literature and finding how we want to answer the gap and the question.
Thank you for sharing that. I think that's always, to me, one of the most difficult parts. And I've been impressed with everyone's creativity in coming up with very important and interesting questions. Anybody else want to share about what was most difficult? Feel free. Or if you have another question, if something else has popped into your mind for one of the presenters.
So, Karen, I really want to thank you for your great facilitation and moderation of these two sessions. Thank you, thank you.
Thank you. Well, I would just like to thank all the presenters, and let me just say that I have not only been impressed with your actual presentations, but really everyone's resilience throughout these past crazy 15 months. And you've plowed through and up and done your research. And so kudos to all of you. Thank you very much.
So we thought probably not 2 hours might be too long to facilitate. So we have a new facilitator that's going to be taking the next two sessions. So I believe Harold Bay is on now, perhaps. Are you there, Harold?
I'm here.
Yes, so I am pleased to introduce Harold Bay, assistant professor in biostatistic. I could be wrong. It could be associate. But anyway, thank you, Harold, for being willing to be the moderator for sessions 3 and 4. And I think we're moving through this pretty smoothly. As you know, I'm going to keep time, and Gretchen will move the slides forward. So it'd be helpful if you just introduce the person who spoke next. Just say their name.
Sure.
Okay, so go ahead, you're on.
Yeah, welcome. I'm Harold Bay. I'm an associate professor.
Yay, okay, thank you.
Please mute your audio except when you're asking questions at the end. And we do encourage you to keep your video on during the entire symposium. Again, the Q&A is at the end of each session. Now we're just about to start session 3. Lastly, we're recording this event, so the Q&A session at the end will also be recorded. So the next person, the first presenter of session 3 is Ellie Smith.
Hi, everyone. Can you all hear me okay?
Yes. Yes.
Awesome. I apologize for my background. I'm traveling for a family wedding, but I'm Ellie Smith. I'm a third-year doctoral student in health promotion and health behavior. Today, I'm giving an overview of a project that I will be conducting via an NIH-funded research training program called the Cancer Epidemiology Education and Special Populations Research Training Program. And the title of this project is Development of a Reproductive Justice Model to Predict Cervical Cancer Prevention Behaviors. And you can advance the slide, please. And so we know that cervical cancer is mostly a preventable disease. However, over 4,000 individuals are predicted to die from cervical cancer in 2021 alone. So aside from mortality, we also know that cervical cancer results in negative physical, mental, social, and financial burdens for survivors and patients. And so therefore, it's really important for us to understand the barriers to prevention behaviors. We know that primary prevention of cervical cancer is avoidance of the human papillomavirus, or HPV, via the HPV vaccine. And secondary prevention is routine cervical cancer screening. And so although we know these preventative behaviors exist, there are many system-level barriers that limit individuals' ability to exercise these behaviors, such as inadequate or no health insurance, language barriers, skepticism due to discrimination in the healthcare setting, and medical mistrust, as well as of a lack of training with LGBTQ+ populations and their cervical cancer prevention care. And so reproductive justice as a theoretical framework recognizes how these system level barriers are a symptom of intersecting and compounding systems of oppression.
that impact reproductive and sexual health outcomes. So in order to really understand how and what systems of oppression limit individuals' ability to perform cervical cancer prevention behaviors, the specific aims of my project are to develop a model utilizing reproductive justice and structural equation modeling to predict cervical cancer prevention behaviors, including PAP testing and initiation of the HPV vaccine. And so I'm going to be using data from the 2014 collection year of the CDC's annual Behavioral Risk Factor Surveillance System survey. And RJ provided my conceptual lens for identifying appropriate survey questions that examine structural and system level barriers to care, such as access to healthcare, the social context of individuals, and experiences of racism in the healthcare setting. And structural equation modeling as a method allows for the examination of the association between all these multiple constructs simultaneously in order to develop a more comprehensive model. And so the study is novel in the fact that it's the first attempt to actually quantitatively model reproductive justice in order to address barriers towards sexual health and work towards achieving reproductive justice. And so the anticipated results of the study can really aid public health practitioners in understanding where to prioritize interventions to develop in order to really address these system level barriers. So thank you so much.
And
Hello,
then
everyone.
yeah, go ahead. Sorry.
Hello, everyone. I'm Gayatri Adni. I graduated with an MPH Epidemiology from OSU in 2020 June, and this research was conducted as a course project in OSU, and it's still work in progress. So in this research, I tried to understand the association between sex hormone binding globulin and diabetes mellitus in women who are in the ages 20 and above using NHANES data set from 2013 to 2016. I also aim to stratify the results based on the menopausal status. A little background, SHBG is a blood carrier protein for the sex hormones, and it is vastly studied in relationship to type 2 diabetes because of its clinical implications in screening for type 2 diabetes. Most EPI studies so far focused on male population, postmenopausal women, and people of European ancestry. So I used NHANES as it is a nationally representative sample and also included premenopausal women. In the methods, I excluded pregnant women and I used self-reported diabetes mellitus for the dependent variable and used continuous variable SHBG from NHANES as independent variable and categorized it into low, normal, and high SHBG. I considered age, race, ethnicity, education, family income, testosterone, and BMI, and menopause as covariates. In the statistical analysis, I compared the covariates and SHBG between diabetes and non-diabetes groups and tested for the difference using chi-square tests. And I found low SHBG were higher in DM group, approximately 50% higher. And however, the cell sizes were very small than desired, about 30 for each of low and high SHBG in diabetes group. And I derived prevalence odds ratio for diabetes mellitus using binomial logistic regression. In the final model, I included race, ethnicity, education, testosterone, BMI, and menopause. I couldn't stratify as I aimed in the beginning because of lack of statistical power for the sample size. And I observed the OR for diabetes is higher in low SHBG compared to normal SHBG. And it was 3.40, and it was statistically significant based on 95% confidence intervals. And this inverse relationship is consistent with the previous studies. However, there was 20% missingness in SHBG that needs to be understood and accounted for. And I want to continue to increase the population size by including newly released enhanced data sets. And also, I want to explore this relationship in longitudinal data sets to understand the temporality and causality of this relationship. Finally, I want to thank Dr. Ellie Smith and symposium organizers for this opportunity. Thank you.
So Wafa, you're up.
Yes. Hi everyone, my name is Wafa Hitani. I'm a fourth-year student at Public Health, Health Policy. My research is about intimate partner violence and utilization for antenatal healthcare services in Jordan. Jordan is a small country in the Middle East, and violence against women, either domestic violence or intimate partner violence, is a huge public health concern and problem. According to the WHO, 1 in 3 women globally have experienced either emotional, sexual, or physical violence by current or former husband or intimate partner in her lifetime. In Jordan, Jordan has the highest rate of domestic violence and intimate partner violence in the Middle East. And according to statistics, 1 in 3 women in Jordan has experienced domestic violence.
So Wafa, I'm going to interrupt you and tell Abby to mute herself, please. Abby, will you mute yourself? Sorry. Okay, Wafa, can you continue? Sorry.
Yes. According to statistics from Jordan, 1 in 3 women have experienced domestic violence or intimate partner violence in her lifetime. And sadly, only 1 in 5 women will seek help to stop the violence. Our study is the first study to study the effect of intimate partner violence on utilization of antenatal healthcare visits. Our goal of the study was to assess the prevalence of intimate partner violence among a sample of equal married women between the age of 14 to 49, and also to examine the association of ABV on antenatal healthcare visits. Next slide, please. Our data, we used the domestic violence model from Jordanian Population Health Survey from 2017-2018. And our variable are the outcome variable is antenatal care utilization, which is the number of antenatal care visits and the timing for the first antenatal visit. And also our exposure variable is intimate partner violence. We have used linear probability model, and we have also used the instrumental variables in order to identify which factor increases the risk for the women to experience the violence. We have found that lower empowerment of women and also witnessing domestic violence as a child increases the chances and the risk that women will be abused during their marriage. Our results indicate that experiencing intimate partner violence will be associated with a decrease in number of visits, and also for the first visit for antenatal visits. And our implication is to promote women empowerment, educate women about their rights, and also adopt women-centered intervention and programs. Thank you.
Hi, everybody. My name is Adrienne, and I'm excited to represent Human Development Family Studies, where I'm a PhD candidate. I work with Dr. Bridget Hatfield, and my research area is the early care and education workforce, particularly those who work in home-based settings. Home-based childcare providers own and operate small childcare businesses in their homes, providing early learning and care most frequently for children from infancy to 3 or 4 years of age. And among families who depend on the care they provide are those from rural communities, families of color, families with children who have special needs, and those who work irregular or non-standard hours. The population of families served best by home-based providers tend to be also those for whom the quality of care is the very most important in children's developmental trajectories. My research is specifically focused on home-based childcare providers' engagement in outside systems of support and resources that enhance the quality of care that they provide. So I received a scholarship from the President's Commission on the Status of Women at OSU to collect my own mixed methods dissertation data on individual characteristics that predict systems engagement among home-based childcare providers in 4 counties in Oregon. And in the midst of my IRB approval process, COVID happened. So I turned gears a little bit and was able to sneak in some questions that additionally addressed workforce experiences during the pandemic. Specifically, what I'm sharing with you today is some extremely preliminary data. I just stopped collecting survey data last week and had an opportunity to crunch a few frequencies and descriptives to share with you today. What I looked at is providers' engagement with COVID resources and supports, as well as the support that they provide for school-age children's distance learning. Home-based childcare providers have a number of pandemic-related national, state, and local resources that are available to them. And here you can see differences between their awareness of and use of some of these resources, as well as some of the challenges and barriers in their access. The ever-changing landscape of needs, supports, and communications during the pandemic has made accessing resources especially difficult and confusing for home-based childcare providers, many of whom work substantially more than full-time hours. In interviews, many shared that they have added an additional 2 hours a day to their already long work days to adhere to the rigorous cleaning protocols required by the COVID situation. One takeaway is that a streamlined process by an entity who already has an existing relationship with providers, in this case, the Early Learning Division, may have helped play a role in providers' utilization of the resources that they provide. Next slide, please. Home-based childcare providers have been caring for more school-aged children and for more hours a day since the pandemic. Pre-COVID, school-aged children might spend after-school hours in care while their parents are finishing their workday. However, with school closings, many children with their distance learning activities have joined the 0 to 4-year-olds in childcare. Study participants described having to make considerable adjustments to the logistics and environments of their programs to accommodate the needs of such a wide age range of children with their diverse cognitive, social, emotional, and physical needs. Participants also reported the hours that they spent supporting the distance learning activities of these school-aged children on top of the activities they've already been doing to enhance the learning of the preschoolers, toddlers, and infants that they also care for. For example, almost 1/3 of participants report directly communicating with the school-aged children's teachers to understand their homework assignments and learning objectives, to work through technology issues, and to help keep children focused during synchronous class times. The flexibility and adaptivity of families during the pandemic has been nothing short of heroic. Home-based childcare providers have been playing a less visible yet essential role in supporting families and children with a grace and resilience that deserves to be noted. For example, despite the new landscape they're navigating, 60% of providers reported being very comfortable in their new role. Supporting their access to resources and supports that can make their work sustainable will continue to be critical. Thank you so much for this opportunity to share this very preliminary data.
Hi everyone, my name is Caitlin and I am a master's student in nutrition, and the title of my research is Knowledge, Attitude, and Practice of Patient-Centered Communications Among Clinical Dietitians. Next, please. So just to add a little bit of context to my research, how many of you have been to a doctor's appointment or really any kind of appointment with a professional and felt like the woman up in the upper left-hand side? Confused, completely disconnected from your provider, and not feeling like you have any clarity or answers. For example, this is kind of me at my car appointments with mechanics. Now think about a time when things just clicked. You experienced a light bulb moment like the gentleman in the photo below. You may be left feeling empowered to make a positive change in your life. How experts communicate their knowledge to us can make all of the difference in how we feel and how we take responsive action. Registered dietitians are nutrition experts, and they too often have difficulty communicating their nutrition knowledge to their clients or patients. In my research, I decided to narrow down my target population to clinical dietitians. My specific aims were to explore the familiarity among clinical dietitians with patient-centered care, or PCC, communication approaches, explore how often they use PCC in practice, identify motivations for using it, and then explore potential obstacles they might encounter when trying to use PCC in practice. My target population was RDs with current or prior clinical experience, and they were largely Oregon and Washington based due to our connection with the local academies of nutrition and dietetics. My team and I developed, pilot tested, and disseminated a survey via Qualtrics. We used 5-point Likert scales to analyze the data. The survey was sent out twice in a 1-month period, and we ran descriptive and inferential statistics for data analysis. Our big picture findings were that the RDs were moderately to strongly familiar with half of the communication approaches we asked about, PCC and motivational interviewing being the most popular. Just under 85% of the RDs had prior communication training, most of which was done via continuing education opportunities, which suggests a potential effective route to offer more of these communication trainings in the future. Trainings seem to be effective as those with prior training increase their application of PCC in practice. RDs across the board of demographics like specific role, years of practice, etc. felt communication training is valuable and are open to learning new communication skills to use with patients. Some of their top perceived obstacles to practicing PCC were fear that practicing empathetic care is emotionally draining, overwhelming patient load, and staffing or time constraints. So the study really serves as preliminary research to help inform development of future communication trainings for clinical dietitians. And I'm especially interested in this because as a future dietitian, I want to be an effective communicator to make an impact on something that affects all of us in so many ways, which is our nutrition.
Hi, my name is Sigrid Janiska Seco, and I am a PhD student in environmental and occupational health. And today I'm just going to talk about one of the chapters of my dissertation, which has to do with assessing air pollution exposure and awareness using low-cost sensors in Gabon, Sub-Saharan Africa. And this is still a work in progress, so I'm mainly going to talk about the reason for the research and briefly go over the methodology. So the map with the dots on the right represent air pollution monitoring stations around the world. But what do you notice? This map clearly shows that there is a lack of air pollution monitoring in Africa, despite air pollution being an increasing problem on the continent. And ambient air pollution is a global public health crisis that's causing millions of premature deaths every year worldwide. And 92% of those deaths occur in low and middle income countries. But most of the monitoring occurs in high income countries rather than in countries where the problem is worse. And in Africa, air pollution has surpassed unsafe water and sanitation as the leading cause of death. But the topic is still highly neglected because government and international organizations prefer focusing the resources on preventing and controlling infectious diseases such as HIV and Ebola. This can therefore explain the lack of air quality standards and data on the continent. So an alternative to a top-down approach to controlling air pollution is a citizen science approach to help individuals, regardless of their social status, learn about the pollutant they are exposed to and make recommendations on ways to reduce their exposures. And this approach is now possible with the use of low-cost sensors, which are now widely used worldwide and have had a high correlation with more expensive and sophisticated monitors for the pollutant they measure. Next. So the goal of my study is one, to monitor outdoor air pollution at fixed neighborhood sites to create the first ever outdoor monitoring network in the country using low sensors to document air pollution. And second, to conduct personal monitoring to document drivers of those exposures. And I will also be conducted a structured questionnaire before and after the monitoring to determine whether monitoring data influences awareness and perception of air pollution. And to build local capacity, I'll be working with local researchers, students, and other community members, because we believe that by having community members actively engaging in the monitoring of their own pollution exposures, that will hopefully help raise awareness about air pollution and start discussions that would lead to actions aimed at reducing pollution levels and protecting human health. And I also hope that this approach will help in filling the gap in air pollution measurement in Sub-Saharan Africa, which is one of the most understudied regions in the world. Thank you.
Okay, thank you. So now we're going to open it up to the audience. So if you have any questions, please let us know. You can use your chat function. You can raise your hand.
I have a question for Sigrid, and I think that's a wonderful project. It's a classic project. Okay, so my question is, because you said that you would try to involve the local community to create awareness and indirectly then or sort of in the pathway, improve the conditions there. But then I think you were not very clear about what you mean by community. Like, we're talking about local population, or we're talking about the industries, because it's the industries which are responsible for most of these issues, and they sort of are not so or they are very reluctant to get into such project, because that would mean an increased expenditure on treating the effluents and the waste and stuff. So how do you think you're going to be involving that portion?
So what we've done, we've been working with local researchers in the past on different projects. So we have two aspects to the project where we have personal monitoring, and personal monitoring will be done by university undergraduate student. We'll be carrying around those monitors to document pollution levels and of course drivers of those pollution. And we'll also have fixed monitors. We're thinking of putting about 14 to 15 monitors around the city. And that will be at household, industries, and other places. And in order to access industries, actually, we'll be working with government officials. So we are in contact right now with the Ministry of Health and the Ministry of Environment to try to get them on board. And once we have them on board, then it will be easier for us, along with the local researchers, to put the monitors there so that we can also document air quality levels there.
Thank you.
Mm-hmm.
Do we have any other questions?
So Harold, I'll ask a question of Ellie. So Ellie, can you maybe provide a bit more rationale for why you think the reproductive justice model is the right model to develop to predict cervical cancer prevention behaviors?
Yeah, thank you, Marie, and thanks everybody. This has been so wonderful listening to all the projects. That's a great question. And so what we've seen in previous research is that oftentimes when we're looking at barriers to cervical cancer prevention behaviors, researchers have typically focused on demographic variables, such as race, ethnicity, SES, things like that, and they haven't quite looked at it on a structural level, using variables that really examine system level barriers. So what this project hopes to do is, instead of looking at, although we will be still looking at the influence of race, we're going to look at racism, right? So we're looking at system level and systems of oppression, which we're able to do using a reproductive justice framework that really looks at not these individual characteristics as demographics, but really pulls it back out to a systems level perspective. So that's just one example. Another example is looking at social context. So maybe not necessarily what your income level is, but are you able to afford healthy foods? Are you able to pay your rent? And do you have access to adequate access to healthcare? And so looking at more at those system level barriers, which reproductive justice aims to really interrogate those instead of those more individual level factors. I hope that answers your question.
Yeah, thank you.
Thank you.
I have one, as maybe a follow-up question to Ellie. I try to think through this too. Do you have plans on how to maybe distinguish things like segregation from people who want to live in maybe a cultural enclave of people who look like them? Because, if we're looking at structural inequity, can you have the motivations?
Yes. Yeah, so that is a great question and a great question for a future study. Unfortunately, I am limited by a secondary data analysis, so I'm limited by what I have available in this data set. And unfortunately, there's just not a measure of something like that, but absolutely that's something to consider. And my hopes is that through this study, we can kind of see that we're able to model some of these constructs, and we can kind of use this as a springboard to do future research, kind of modeling these constructs and using reproductive justice as a conceptual lens for quantitative analysis. I hope that answers your question.
Very well, thank you.
Thank you.
I have a question for Wafa. Because partner relationship violence often elicits feelings of like fear and shame, I would imagine that that would impact the amount of information or type of information that people are willing to volunteer. But I was wondering what your thoughts were on that and how it maybe impacted the study.
So there was a question to Wafa. I think you're muted. Wafa, you're muted.
Sorry. Yeah. Can you repeat the question, please?
Yes, of course. So I was just saying how a lot of times when there's relationship and violence in a relationship, it often elicits these feelings of fear and shame. So I would imagine that that would impact the amount of or type of information that people are willing to disclose. But I was wondering what your opinions were on that and if it affected results in any way.
Yeah, it was in 2018 actually, and there is also the stigma about reporting being abused by your husband, especially in like in an area in the Middle East. Of course, your concern is it's right, because even though when we like study those variables, there is some question that there is no answer, like sexual abuse. Less and less women will report this kind of information, and I think there is the stigma, and then also there is the community that doesn't support women to report this kind of violence.
Cool, thank you.
You're welcome.
Thank you. So we have 1 minute until the next session. Marie, how do you want to do it? Should we?
I think we're close enough. If no one has any more questions, Harold, I think you can just go into the final session.
Okay. Yeah, so now we're going to move on to session 4. Again, the same rules apply. So please hold your questions until the end. We will have a Q&A session. So the first presenter of session 4 is Sulaiman Doza.
Hello, thank you, Dr. Harold. I'm Dr. Sulaiman, and I'm a doctoral student in the Environmental and Occupational Health program at OSU. Today, I'd like to present a brief report that I did as part of our surveillance research project called RISK, which is tracking fishermen's health and injuries in the Pacific Northwest. And here we utilize a web-based interactive tool known as the Worker Health Charts by NIOSH. And in this website, they reported the prevalence estimates from several national household surveys such as NHIS, BRFAS, as well as case report surveillances such as EBLS and Sensor. And of these, we identified 2 surveys, the BRFAS survey years 2013 to 15 and the NHIS Occupational Health Supplement year 2015, both of which reported the occupational subcategory fishing and hunting workers. Now, this was relevant for us because our aim was to compare the prevalence of adverse exposures, health behavior, and health status between fishing workers with other agricultural workers and all workers. Please go to the next slide. And here we compile some key findings which showed that the fishermen commonly reported work-life interference, like if you look at the bar chart on the left, and low supervisory support, as well as high job demands, all of which indicating adverse psychosocial health effects. And among the health behaviors, fishermen commonly reported smoking, as well as secondhand smoke exposures, both of which can increase their risk of respiratory illnesses. And chronic conditions like severe low back pain and carpal tunnel syndrome were also prevalent. And all fishermen in the survey reported that their work required frequent standing or walking, and they often lift, pull, or bend to carry out their tasks. Now, this actually supports that their high prevalence of chronic musculoskeletal injuries that they reported. In conclusion, the fishermen had higher psychosocial general exposures and both psychosocial and general exposures, as well as chronic conditions compared to other worker groups. At present, there is a lack of surveillance efforts to track the overall health of the commercial fishing workers because it is fairly expensive to carry out such service for a particular occupational subcategory. And our brief report actually showed that the National Household Service, such as PARFAS or NHS, can be a good resource to explore health status of the fishermen or any similar worker groups in the US, though the estimates should be interpreted with caution because of a relatively small sample size in the surveys for the occupational subcategories. Thank you.
Hello, my name is Justine Meyer. I am a MPH public health practice student, and I'm sharing our research examining food insecurity among college students attending OSU during the COVID-19 pandemic. Prior research on food insecurity at US colleges has showed a significant range as far as estimating prevalence, with noted differences in methods, especially survey modality and sampling. So Dr. Jackson and Dr. Edwards initiated research with a team of students to conduct the first assessment of food insecurity across OSU's student body. The goals were to explore sampling methods comparing a campus-wide email sample, which is common among the research, and then a course visit sample. We also sought to estimate the prevalence of food insecurity and identify risk factors in OSU students, as well as inform policies and help target interventions to address the problem. We started with the Corvallis course visit sample and then the campus-wide email sample. The same process was conducted for the Cascades campus and only the campus-wide email sample for eCampus. We used the USDA Food Security Survey module and screener, and then we added demographic questions to include race, ethnicity, first-generation college student status, gender, employment, funding, and living situation. Next slide, please. And we have completed the analysis of results for Corvallis and have preliminary findings for Cascades and eCampus. So for our course visit samples, there were less food insecure students when compared to the campus-wide email samples. There was a much higher response rate for our course visit sample, which we suspect yielded a more accurate estimate of food insecurity. From the Corvallis sample, significant differences in food insecurity prevalence were observed, with higher rates in third or fourth year undergraduate students, those who are first generation college attending, and there were differences by race and ethnicity, but those were largely explained actually by first generation college status. Recipients of SNAP had higher rates of food insecurity, as did the students who were living in local counties, while those living with family had lower rates of food insecurity. The significance we found is that with both sampling methods, students showed higher rates of food insecurity than recent household figures for the state and surrounding counties during the COVID-19 pandemic. Our campus-wide email surveys may actually be overestimating food insecurity figures due to a non-response bias. Public policy strategies, including SNAP, need to target improving food security among college students. And additional research examining survey methods on college campuses will help to determine the most accurate method to assess food insecurity and should further evaluate those underrepresented groups in the research. That's it. Thank you. Hi, everyone.
Today about a study that we conducted on youth running biomechanics and specifically the influence of footwear. So I apologize, my font is small for our screens, but we'll go through everything. So we investigated the effects of footwear on running biomechanics in youth, specifically 14 male participants between 8 to 12 years old. we had 3 different footwear conditions. We looked at them in our minimal shoe, which is the black one you can see at the center of your screen, a traditional running shoe, which is the blue one right next to it there at the center of the screen, and last but not least, but a barefoot condition. There has been quite a bit of research on running biomechanics and footwear in adults. There has been very little on youth. And so this study was somewhat unique in that regard. And we were hoping to better understand the effect of these different types of footwear on youth and, you know, again, getting a better sense of how these different footwears were affecting our population of interest. Our results demonstrated that there was a very substantial increase in vertical ground reaction forces, specifically in average vertical loading rate in both the barefoot and the minimal shoe condition. You can see this in the graph at the top right hand of your screen. The blue bar there is showing the barefoot condition. The gray bar on the far right is showing that minimal shoe condition. And then the much lower bar in the center is showing the traditional shoe. So average vertical loading rate is a biomechanical variable that's very closely associated with chronic repetitive stress running injury. And therefore, we were very interested in this variable. And we found that the minimal shoe very closely mimicked the barefoot condition, and both of those conditions significantly increased the average vertical loading rate. We also saw some changes in kinematics, or the way that the individuals were running. Interestingly, in many of the kinematic variables, it appeared that the minimal shoe was more closely associated with the traditional shoe, and so shod kinematics were quite a bit different from barefoot kinematics, where again, in the average vertical loading rate and ground reaction forces, the barefoot and minimal shot or barefoot and minimal conditions were much more similar. The kind of key take-home point from this research, especially for any individuals who are making footwear decisions for youth that are running, is exercise caution with the use of minimal shoes and with the use of barefoot running. Because of those increased vertical loading rates, we would be concerned that there may be some increased risk with chronic repetitive running in those types of footwear and relative to injury. And certainly we hope to do more research and investigate this topic around youth running footwear and associated biomechanics more in depth in the future. That's all I have. Thank you.
Hi all, my name is Lauren Chan. I'm a PhD candidate in nutrition, and today I'm actually going to be taking a bit of a detour from nutrition and discussing a project that I was working on that looked at the usage of COX inhibitors and their impacts on COVID-19 severity in individuals within the National COVID Cohort Collaborative. So the N3C is a large consortium group that was set up by NIH NCATS at the start of the pandemic, and it functions as a data enclave with electronic health record data from individuals within 53 different sites. And it also has information from over 5 million patients, with about 1.5 million of those individuals being COVID positive. So we were interested in utilizing this platform to evaluate the impacts of cyclooxygenase inhibitors on COVID-19 severity. COX inhibitors are a class of drugs that are intended to reduce inflammation and pain, and they include common NSAIDs like ibuprofen and acetaminophen. So this group of drugs has previously been associated with impaired immune function and also the masking of infection. So in terms of COVID patients, they could potentially pose a risk by reducing immune activity and delaying treatment for COVID. Next slide, please. So to evaluate COX inhibitor effects in the N3C enclave, we looked specifically at COVID-19 positive patients and identified patients with indications that they might be prescribed a COX inhibitor for. So looking at COVID-19 positive patients with one of the indicators, we then evaluated records of drug usage and separated into indication subcohorts of COX inhibitor users and non-users. And then this developed about 21 on-drug, off-drug subcohort pairings. Between each subcohort pairing, we then utilized propensity matching and ordinal logistic regression to compare the on-drug and off-drug groups for their COVID severity outcomes. So on the right-hand side, you can see a small bit of our results. Within quadrants A, B, and C are comparisons of individuals with osteoarthritis that were using aspirin, ibuprofen, or acetaminophen, respectively. The non-users are in red and the users are in blue, and COVID severity scores increase as you go along the right on the x-axis. So you can see that within all three of these on-drug groups, the blue bars are significantly larger on the right-hand side within those moderate, severe, and in some cases, the mortality hospice categories, compared to the more mild outcomes seen for the off-drug individuals in red. And in quadrant D, the entire cohort of COVID-19 positive patients was evaluated for aspirin and severity of COVID. So the on-drug individuals had greater rates of moderate, severe, and mortality hospice ratings when compared to off-drug individuals in that group. So this observational study utilizing de-identified COVID-19 patient data using this N3C enclave points towards an association between COX inhibitor usage increasing the severity of COVID-19 outcomes. And we look forward to doing some further research to evaluate the specific impacts of COX inhibitors on infections such as COVID-19 so we can better understand this relationship. Thank you.
Am I supposed to talk? Okay. Hi, everybody. My name is Lucy. So my research is about the willingness to use and satisfaction of primary care services among local immigrants in Shenzhen, China. So China is experiencing transformation in healthcare system. So we are trying to promote primary healthcare in the city and in the urban area. So Shenzhen is one of the most biggest city in China with a lot of migrants. So in this study, we are trying to identify the difference between local and migrants on utilization and satisfaction of primary healthcare, which is community healthcare center, also called CHC. So it is the primary healthcare provider in urban area. In this study, we identify migrants in two ways, by hukou status and living status. Hukou is household registration system used to identify an individual's residency as a rural or urban area. And then urban village is a really special phenomenon in China. So a village that is appear on the outstreak and downstreak segments of major Chinese cities. Please go to next slide. Thank you. So the data is collected in 2019. It is a community diagnosis questionnaire. So 3 outcomes were evaluated, including knowing the location of CHC, frequency of visit CHC, and satisfaction levels of CHC. Okay, the 2 main independent variables were identified as hukou status and urban villager status. So we found that the migrants were less likely to know the location of nearest CHC and less likely to use it. And then also no significant relationship was found between hukou status and willingness to use CHC or satisfaction of CHC. So our implementation of this study is there needs to improve the accessibility and affordability and willingness of migrants to use primary health care in the city setting. Thank you.
Thank you. So now we have about another 10 minutes for the Q&A. Please let us know if you have any questions about any of the presentations. These were really nice presentations. You can use either the chat or raise your hand, either physically or using the reaction.
I have a question to Andrew. Is he?
Yes, hi there.
Okay, yeah. So your research is on people like, running, but then I was just wondering whether the same results which y'all got can be sort of applied to even a fast-paced walking or a general walking, because basically it's basically, how you land on your foot, like whether it's walking or jogging. So whether the same results can be sort of applied there?
Yeah, so it's a great question. In general, no, we do not assume that running biomechanics and walking biomechanics are the same. We actually did do the same procedure in walking with these participants. That data was not presented here, and the results which we found were different. So we found that the kind of variable of concern in relation to average vertical loading rate, so kind of the rate at which the vertical ground reaction forces are applied to the individual, is not nearly as substantially different in walking when walking in the different types of footwear as it is in running. In general, we worry much less about repetitive stress overuse injury in walking. And I think to some degree, we're all familiar with the very different characteristics of walking and running in terms of impact. And I guess the short kind of summary to answer your question is that they are substantially different, and the variables of concern are much more prevalent in running as opposed to in walking.
Thank you.
Yeah, of course.
So I have a question for Justin on the food insecurity.
Yes.
Yeah, so I was a little surprised that a lot of the students at OSU have the food insecurity issue. I was a little sad to see that. But do you think, and I'm sure you might have got a similar question, but do you think the food insecurity worsened after COVID, or essentially, is there an impact of COVID on food insecurity among college students?
Thank you. It's a great question that we ponder as well, because we don't have a baseline of food insecurity among OSU students before COVID. So we have to kind of look at regionally kind of what the reports are, and what the expectation is that, I mean, throughout the country, but we have specific estimates for Oregon and for even the local counties, and it's expected it to be increased. So we would assume probably that it was lower before COVID, but it's hard to know because it's not well studied. There's a few other research articles that have come out where they tried to look at like a baseline before and compare to after COVID at some other college campuses, and it's kind of mixed. There's some students whose food insecurity actually improved at other college campuses, while other students got worse because we have all these different fundings and programs and so many things in the mix. So we can't really tell from our research or that much from even other research out there to answer that kind of question yet.
Yeah, so because I think, I know the university administers some type of surveys, not every year, but biannually, to study students' behavior. So I'm assuming those surveys probably don't have anything about food insecurity.
Not that we've been aware of. So this was as far as we knew, like, because this project was requested so that we could kind of define what the food insecurity rate is for OSU students. This was kind of well before COVID. It just kind of happened to line up the time frame and hit the COVID pandemic, but it was identified well before that by a task force that we needed to investigate this.
Sure. All right. Thank you. Now we have a question from the chat, and it says, I might have missed this. Did you look at student status, like international students versus domestic students, or graduate students versus undergrad students?
We did ask about like school year level. So we looked at graduate, doctorate, undergraduate years, and the significant difference we saw was in the undergraduate group and seeing that higher rate in the 3rd and 4th year. And then we didn't have like an international question for on campus. I know for our eCampus survey, the questions were just a little different because we actually have people everywhere for eCampus. So we did ask for that survey if you lived in the United States or not. And that's still preliminary. We're still doing the full analysis for eCampus.
All right.
And I just
Harold,
the reason I had asked,
oh,
sorry, the reason I had asked that is because of the whole notion around international students and some beliefs that they're not eligible for HSRC resources. And that's kind of one of the myths that we're working on dispelling on campus. I feel like that would be a huge equity issue for our community. So something that I think people should be advocating for that survey, whoever's involved in that development, advocating for an inclusion of that question.
That's a great input. Thank you.
So I'm noting that Kendra has her hand up.
Oh,
Kendra.
yes. Yeah, this one's for Lauren. It was really great to see work that kind of supports or furthers kind of the theorized inflammatory response and how that's implicated in COVID. In your propensity score matching, did you notice that, or I guess when you thought through what to match for, what variables seemed, significant in getting at whether this was like a causal relationship versus just like a higher comorbidity relationship? I know that was a kind of a big picture question, but.
Yeah, so we looked at our propensity matching included age, race, ethnicity, gender, smoking status, comorbidity index score, and BMI. And there's, for the most part, it's things that you would kind of presume would happen. So a higher age was associated with greater risk, higher BMI. And then there seemed to be a little bit of a trend towards males as opposed to females and higher risk with smoking status. So it's kind of the things that you would like anticipate.
Yes. I was just, so was the comorbidity score, did it seem to be?
Oh yeah, sorry. Yes, greater comorbidity scores did seem to trend with the increase in COVID severity.
Yeah, great answer. Thank you.
So Harold, I have a question for, is it Solomon, the worker health chart summary presentation. And my question is, I noted that you had fishermen and fishing and hunting together in your charts and in your findings. Right. Was the data collected for both? And were there any thoughts on that?
Okay, so what happens with this National Household Surveys is actually people report their occupations as it is, and then those who kind of clean and manage the service, they actually record those responses to specific standard occupational classification categories. And so they kind of, earlier surveys actually had like maybe 15, 20 years back, they actually had a fisherman specific category, but now they kind of merge fishing and hunting workers. But I actually try to explore to kind of get a better idea of like what is the proportion between these fishing and hunting workers. And it seems like that even in the recent surveys, those who try to look at the hunting workers, it's relatively rare in the US, compared to the commercial fishermen. So we kind of assume that these workers are kind of dominated by the fishing workers. Yeah, but that is actually a limitation of the report. But I was really glad of this report because it only used the web-based estimates, and we didn't really actually analyze any data, but still were able to get some insights. Thank you.
Thank you, that was helpful. So Harold, I'm watching our time. I'm wondering if you have anything to add here before we make a few closing statements.
Sure, yeah, I don't have any questions. It was really a great work, just in the depth and the breadth of the research was just great. I had personally many more questions, but I kind of saved it for other people. But great job, guys.
So I would like to first thank Harold for moderating, and then of course thank all of the speakers. I agree, this was very wonderful and the breadth was outstanding. And I really take away how important this work is that you all do to improve the health of various populations. So it's outstanding work. You all did a great presentation. You stayed on time. And I really thank you all for participating. And I thank the audience who participated as well. So with that, I think we will adjourn. So thanks again, everybody.